Testing 1 2 3. Testing 3 2 1.
Test and stream. 1, 2, 3. Test and stream. 1, 2, 3.
morning, everyone. Um, let's go ahead and call the HR committee a meeting to order. We do not have any citizens, anyone wishing to address the committee. So our next item on the agenda is the approval of the minutes. Are there any corrections to the minutes?
Dorothy, if there's no corrections, I'd recommend approval.
All
I'll
right.
second.
All right. It's been motioned by Charlie, second by Zim. All those in favor signify by saying aye.
Aye.
Those opposed by nay. Okay. This meeting should be pretty short today, gang. Because
Don't say that.
well, yeah, it's going to be pretty short today because what I've asked staff to do, and I'll ask you to look at our annual LTIP in two ways. We looked at it at 6 months. That was 6 months into our fiscal year. We were clicking along, everything was fine, and then COVID hit. And so what I'm asking is that we look at where we were at 6 months and let that be our annual, use that as our annual incentive. Because I believe if COVID hadn't hit, we would have continued and met those metrics where they are. But at the other end of that spectrum, we've been into COVID now 6 months. So at our fiscal year end, we now have our performance at that end. So what I'm asking is, when we look at that, we use 6 months data into COVID as our baseline for next year. Okay, I think that's pretty fair. That would show that what we were doing before COVID, because when COVID hit, we had to close the close the clinics. We had to make all kind of changes. But what that does is says at 6 months, this is what we could measure. That meant that physician engagement and employee engagement would not be a part of that matrix. Okay, so you had to give up something in order for this to be fair. But at the year end, we have that information, so I'd like to use that as our gauge for our goals for the next year. Any questions on that? Okay, Karen, you want to go through our results for us pretty quick?
Yes, Dorothy and the board, if you just give me a few minutes. First of all, Mr. Chairman, I'd like to thank you and the members of the board for just being there for us, for being available when we called for advice, being available when we asked you to participate in many of the RFPs that were going on, and more importantly, for the support that you have provided us over this last fiscal year. So I do want to start by just expressing the gratitude of the executive team. With that said, Dorothy, I'd like to thank you for all the support and wisdom you've provided me. This is a new for me to present AIP and LTIP, always dangerous territory. But you really did give me a lot of support as we work to determine how best to reflect and give credit to the enormous amount of physical and emotional sweat our JPS teams have endured through a very different 2020 year. As Dorothy mentioned, we are recommending that we base our AIP and LTIP award on the work we completed through March 31st of 2020. As she said, JPS began to experience the impact of COVID on hospital operations in March of this year. Our resources and our energies were shifted to create and build new care spaces overnight, secure scarce PPE, repurpose our staff for new COVID positions, and develop new treatment and care plans, and finally leverage and optimize our technology to allow for remote work and remote patient visits. By the end of March, we had developed and implemented real-time and proactive COVID plans instead of a hospital COVID command center, and more impressively, a clinical steering team that has been led by Drs. Hochberg, Stevenson, and Davis, which allowed for us to present information that was forever changing, to act upon it and decide on best decisions for our patients and for our staff, and to communicate out to them. Both the clinical steering team and the hospital COVID command center continue to operate today, to just show you how sustainable that has been. As you recall, following the governor's order in March, in mid-March of this year, all non-essential business was suspended, and over 1,500 of our staff members began to work from home for the first time. David will attest to the hard work that the IT team did to get them in place to do that. And many of them continue to work from home as we continue to monitor safety here in the hospital. New hires were suspended at that time. Visitations were restricted in most of our care settings. Elective procedures were suspended, and clinics were closed for non-emergent clinic visits. And despite the confusion and uncertainties that were surrounding us, Robert and I daily commented on the extraordinary resilience and adaptability of the JPS team. We mobilized quickly, we worked collaboratively, and we tirelessly across the network, and more importantly, demonstrated compassion for one another. The exhaustion and the fatigue of our frontline providers, our nurses, and our support services is visible and is palpable. And it is visible and palpable today. And yet our teams continue to leave their homes and their families to come here to provide care where and when needed. So I want to give thanks to our team. Although it is not a time any of us desire to return to here at JPS, I personally could not think of a better place to be and a better group of individuals to be surrounded by. So thank you, Dorothy, for allowing me those words.
All right.
So with that said, if we can have our first slide up. Our next slide, please.
What I want you all to do as board members is when the slides come up slowly, I want you all to look at David Mendenhall's face.
Yes,
That's the best thing to do during this time period. It will be a source of interest.
There we go. I wasn't sure whether I need to send Lauren back there to help out. So we're going to go ahead and review our achievements through the end of March. Remember, each pillar has a weight associated with it and located under the pillar on the left side there. This is our annual incentive plan for our leaders. And so you'll see several slides that we'll be able to get through the other slides fairly quickly after getting through this one. Our first pillar here is quality, and it's our PSI 90. Dr. Stevenson has presented at every board quality committee meeting over this past fiscal year the tremendous amount of work by the care teams alongside with the quality teams to improve our coding, our documentation, and our process improvements to reduce the number of potentially preventable hospital-related events associated with harmful outcomes for our patients. Just a reminder, this is a risk-adjusted and weighted average of observed to expected for 10 patient safety indicators and is hospital-specific. Again, a reminder that 1.0 is what we would expect here at JPS for the acuity and number of patients we care for. And as Dr. Stevenson always reminds us, we should always strive to do better than what is expected of us. And so that team did work hard to do that. We started the fiscal year at 0.91. Remember, lower is better. And we ended at the end of March, we achieved stretch with a PSI 90 of 0.78. Wow, great work. Yeah. Our second pillar is service. We have a service measurements both for our inpatient and our outpatient. HCAHPS helps us measure our inpatient perception of care. And again, across 9 HCAHPS dimensions, we measure the number of dimensions that were achieved at or above the 75th percentile. We started the fiscal year at 4, and by the end of March, we achieved between target and stretch at 5 out of the 9 dimensions. Again, great work by the team. And again, just reminding you to remind you that the 75 percentile places us the top quartile percentage of achievement. So that is heavy work. Our outpatient experience measurement for outpatient perception of care, we measure the average percentage of top box scores for 10 total survey questions following visits in our primary specialty and women's health clinics. We started fiscal year 20 with an average of 64.9% of the responses receiving top box scores and ended March between threshold and target at 65.6%. And as Dorothy said, she had no doubt that that group would continue to trek along and probably reach stretch had we not hit COVID. Our third pillar is people. We looked at three things. The first one is our first year turnover rate. This metric is measured by Saratoga, and it looks at the percentage of voluntary terminations within the first year of hire. We started the year fairly high at 38.67%, and although we improved to 34.08%, we did not meet threshold by the end of March, and so no credit will be given for that. Employee and provider engagement, those, to just remind the board members, are measured annually in the fall using our employee survey through Crescani. And so this survey was not completed, it was late this year, was not completed until November of this year. We will be using those results to set our new goals for next year. And again, no credit was applied to these two metrics. Our last pillar is stewardship. Sharon has extensively talked about our modified cost per adjusted admission at the Finance Committee meeting. It is too complicated for me to go into, but it's basically a calculation of our total operating expenses divided by adjusted admissions. We started the fiscal year at $12,965 and ended in the end of March at $13,829, and that is considered to be stretch based upon where we set our different targets. Any questions? If not, we can move. If not, we can move on to the next slide, please. This looks very much like the last slide that I went through, so I will not go through each one of them. The only change here, this is for executives, is our stewardship pillar goal is the hospital operating margin, and this is for VPs and above. We started our fiscal year at 2.96% operating margin, and we ended the end of March. If we were to close the year at the end of March, we would recognize an operating margin of 7.50%, which is stretch. Our next slide, please. Just to remind the board that we have 4 physician executives. By definition, these are our physicians that also are credentialed and privileged here at the hospital. And so they play a dual role in assisting the executive team and also have some clinical presence. Again, the only difference with this is the weights themselves. Stewardship was removed from their goals.
Okay.
So Dorothy, if there's no questions on the AIP, I will move to LTIP.
Okay.
Okay. LTIP, here you see for executives. Remember, the LTIP is for the executives, our long-term incentive plan. We have 2 metrics. The first one is quality, and that was the Leapfrog Hospital Safety Score. This score is assigned, just to remind you, is assigned to over 2,500 general acute care hospitals across the nation, and is twice annually measured and reported out, and is a measure of patient safety. It takes into account 28 national performance measurements as set by CMS, and looks at both process measures and outcome measures. In fall of 2019, we received a score of 2.9028, which is grade of C. And in spring of 2020, we received a slightly lower score of 2.8522, thus not achieving a threshold. So no credit there. For stewardship, it is the same that we have with our AIP, so I will not go through a definition there, and the result would be resulted out at the same, at stretch at 13,628. For the next one is our physician executives and their stewardship. They do not participate in. They agreed for physician alignment. This is different than physician engagement. And again, because that survey was not completed until November of this year, there's no credit for that. Any questions? If not, we can go ahead and look at next year. So our proposed goals for next year, I want to start by saying as we began to meet late summer of this year to set new goals for 2021, it's hard to talk about 2021, but looking forward to it, we took into account that COVID would continue to be a factor in our daily operations and that we would be entering a new normal. In fact, we have entered that. Lauren Poe, our Executive Director of Strategy, and I think she's somewhere here in the pictures here, assembled several multidisciplinary work groups composed of executives, leaders, and frontline staff to help develop goals for 2021. We had a lot of activity, and a number of proposed goals were presented before the executive team, and the executive team settled on the following goals. You will see that 5 of the 6 metrics are the same as fiscal year 20. The executive team felt strongly that these metrics remain important as we continue in this new normal. The baselines for each of the metrics were established using the fiscal 20 in-year results, as Dorothy mentioned, and our threshold, target, and stretch values were then calculated based on recommended improvements for each metric. So this is going to be an easy one to go through. The first 5 are ones that we have already gone through earlier. We do have for each one, and I'll go through quickly, for each one, there are new baselines set. We ended the fiscal year 20 for our PSI 90 at 0.90. And so that was set for a threshold for next year. Our target will be at 0.88 and our stretch would be at 0.83. And this is going to be huge work because Dr. Stevenson and his team have done just amazing work. And so to continue through COVID and to work for these goals is admirable. Service, our HCAPs for next year, we ended the year at 5, much like we did mid-year. So we set that as threshold, target will be 6 and stretch 7. For our outpatient, we ended the year at 62.4%. We set threshold at 62.4%. Our target is 63.4% and stretch is 64.4%. For employee engagement, we ended the year, and Alex will return at the next HR meeting to go through our employee engagement and provider engagement scores, but we ended the year at 4.20. And so our threshold was set a little bit higher at 4.22, our target at 4.23, and our stretch at 4.27. We do realize that our employees are engaging in different ways, and we have a strong HR team that will help us across the organization prepare for a different kind of engagement.
Karen, this is Steve. I'm sorry to interrupt. May I ask a question on engagement?
Yes, please.
And maybe Alex can chime in. Can you just kind of give me a really high-level explanation of what that means? What engagement? How do we measure engagement? I'm sorry, Alex, I can't hear you.
Sorry about that. Sorry about that. I was on mute. So the engagement scores are really about alignment of values. Can you hear me on? Okay, I hear an echo. Oh, I'm not sure I'm working here.
Yeah, you're
fine.
Yeah.
I'm good. Sorry about that, Ms. Montgomery. Yeah, it's an alignment of values, and the maintaining that value of engagement is obviously important throughout the organization as it relates to our employees. I can give you a very detailed overview of how Press Ganey measures that. But for this conversation, I'll share with you that on our engagement survey, we compose 6 questions that speak to engagement specifically, and those questions are multifaceted, and I can provide you in a detailed email what those questions are and discuss the importance of each question, which is a lot more than probably I have time for in this.
Oh, sure. No, okay. So it's these numbers are the result of a survey that we implement to our employees.
That's right. And the engagement score is set from very specific questions within the engagement survey that drive those responses that result in our engagement score.
Okay. Yeah. Separately, if you wouldn't mind,
sure.
No rush, but sending me that. I'd just love to look at that. Thank you.
I'll have that out today.
Any other questions?
Nope.
Put me on mute. Not fair to Steve, I just wanted to say that that's a question that often comes up around engagement versus alignment. Engagement really speaks to how engaged that employer provider is in the work that they do, how they value that work, whether they would recommend the hospital to others, whether they would remain at JPS, whether they would recommend that others come and work at JPS. So all of those really speak to how they feel about the organization. When you look at alignment, especially with provider alignment that we used in the LTIP, it's more around how the providers feel that they align with what the executive team has set for strategy, for goals. Do they have a voice at the table? Do they feel that they are in agreement with often what is they're directed to do? So I hope that helps you
No, it does.
understanding the difference between the two.
No, thank you very much.
Provider engagement here again. We ended this year's survey. Again, the survey is given by Press Ganey. It is an apples-to-apples survey, meaning they're the same questions that were asked last year. We ended the year at 3.97 and set our threshold a little higher at 4.01, our target at 4.03, and our stretch at 4.06. I'm going to allow Zelia to speak to the new population health metric that we will be adding next year. We did feel that the 5 above were sufficient for us, but after presentation and discussion with Zelia and her team, we decided to put this one forward. So Zelia, I'm going to allow you to present this last and new goal.
Thank you, Dr. Duncan. Good morning, members of the board. I think it's important to paint the picture of why this goal is important. Prior to the COVID-19 pandemic, statistics indicated that Tarrant County had one of the highest rates of depression and highest rates of suicide in our DFW and surrounding counties. As you all know, COVID has had a significant impact on the mental well-being of our community, and the number of residents in the community reporting depression has significantly increased since the start of the pandemic. If you recall our previous presentation that we did with Tanisha Kennard, our call volume and our clinic visits have actually gone up during COVID. Our leadership team feels like that this metric is very important for our organization because it's a method to track our performance towards the ultimate goal of providing whole person care and proactively identifying and managing the mental health needs of our patients. Addressing mental health is a necessary part of whole person care. Mental health has a ripple effect with regards to a person's ability to manage other health concerns, and effectively integrating mental health and physical health care will result in better patient outcomes. According to the World Health Organization, people who are depressed are 30 times more likely to take their own lives than people who are not depressed, and 5 times more likely to abuse drugs. This measure being proposed is a national standardized CMS National Quality Forum measure. And I know you all have had an opportunity to already review the metrics, so I'm open for any questions.
So Bama, an 8.09, that's I guess a composite of those various scores from the national standard. I mean, does that reflect a 8.9%? Is that specific to the number of people who are in remission, or is it far more complicated than that?
So currently this 8.09% is our current status with our connection patients with them going into remission within 12 months of being identified as depressed. So we have an opportunity to significantly increase our improvement in this area.
Celia, do you want to just go through this metric itself by definition?
Sure.
And how?
I'll be glad to. So the metric statement is to increase the percentage of JPS connection patients who achieve significant improvement in their depression within 12 months of their initial positive depression screening using the PHQ-9 depression screening tool. And that's a national evidence-based screening tool that JPS utilizes. Our definition and methodology: JPS connection patients age 18 and older with a diagnosis of major depression or dysthymia and an initial PHQ-9 depression screening score greater than 9 who demonstrate a significant improvement at 12 months, defined as a PHQ-9 screening score less than 5. This measure applies to both patients with newly diagnosed and existing depression whose current PHQ-9 screening score indicates a need for treatment. The denominator will be adults age 19 and older with a diagnosis of major depression or dysthymia and an initial PHQ-9 screening score of greater than 9. The numerator, I'm getting all tongue twisted today, sorry about that. Adults age 18 and older with a diagnosis of major depression and an initial PHQ-9 screening score greater than 9 who achieve significant improvement at 12 months is demonstrated by a 12-month PHQ-9 screening score of less than 5. A person who achieves a follow-up PHQ-9 screening score of less than 5 is considered to be in remission for depression as their signs and symptoms have greatly reduced or disappeared. And so then we've set our baseline threshold and targets. Baseline is 8.09%. Our threshold is 12.68%. The target is 17.28%, and our stretch is 21.87%. Currently, everyone every patient that comes to JPS is screened for depression through the PHQ-9 score. In all of our community health clinics and all of our behavioral health clinics, we do this in inpatient settings as well. And so we have the ability to currently track where we are. And what is important is that right now we've been screening, but the focus is going to be on the interventions. Not that we haven't been doing interventions, but we're really focusing on intermissions with the goal of remission. And I think that's the difference. And that's why this goal is extremely important, because we're tying it all in. And we have, through our EPIC EMR system, if you score at different levels within the PHQ-9, there's interventions that come up. If this is your score, this is what you need to do. If this is your score, this is what you need to do. If it's urgent or emergent and life-threatening, we have the ability to see that patient in behavioral health clinic then, either through televideo or in person, whichever the patient, whichever the provider feels comfortable doing. And so it's more than just identifying that they've got depression, it's actually intervening and making a difference in their lives to improve their depressive scores.
That's great.
Okay, that's good.
May I ask, if someone exits, you talk about a follow-up survey, if they exit our system and aren't followed up, or don't get a follow-up interview or analysis, are they removed from your denominator? And this may be a conversation you and I have separately. I'm interested in how this is a great measure, and I'm really enthusiastic supporter of it. Just interested in how it's measured. But you and I can talk separately about it. So
Yes,
sorry, I don't mean
yes, we have an intensive group of individuals who will continuously contact individuals. They won't be falling out if we can help it.
Yeah.
Great. Thank you.
Okay, Delia, I'm looking at this. This is like if you score 9, you are working to reduce that so they're under 5. So our goal is to have more of our patients reduced from that 9 down to 5. That's what you're trying to see, that you are increasing the number of patients that go from a 9 back toward 5, right?
Yes, ma'am. 9 or higher. Mm-hmm.
All right. Okay. Great. I love that one. Mm-hmm. Anyone else have any questions?
Just a quick question, this DT. Do we have any program in place to support their families for preventive instead of intervention once they're already in?
We do. We incorporate the families in their care and treatment as much as a patient will allow us to. We also have family support programs as well, and a lot of the interventions is teaching families and the patient how to live with this and get better in what they need to do to take care of themselves.
Sounds great. Thank you.
Thank you.
Zelia, this particular area really is heavy with me, especially in the environment where I work, or serve, I should say. So your numbers are only based on who you see at JPS, correct?
Correct.
Okay. Okay. Is there any way to track basically what the county experiences outside of JPS?
Not at this time. Not for us. Okay. Lauren says she can speak to this.
So from a county perspective, Zelia's right. That data is actually very hard to obtain, and it's only done every 5 or so years, and it's all self-reported. So we do have that data as part of our community health needs assessment every 3 years, but it's very dated, and it's not done on a regular basis. So it's a little hard to gauge real time the improvements there, but it definitely is something that we look at internally as part of the overarching community health needs assessment data that we get every 3 years.
So there's no way anyone reports out suicides more than depression, the suicide rate that takes place within the county?
There is.
Do we have that number?
Yes, sir, I do. There is suicide rates, although they're like a year or 2 behind. So the rate I'm getting ready to give you does not encompass the pandemic and the impact that's had on everything. But for the most recent suicide rate, so Collin County was at 11.1, Dallas County was at 11.8. Denton County was at 10.2 and Tarrant County was at 14.2. And so that's a national suicide rate. It's per 100,000 persons. So 14.2 individuals per 100,000 persons, and that's all age groups.
Okay.
So as you can see, ours is significantly higher here in Tarrant County.
Right. Okay, thank you.
Do we have
Yes,
any indication of why is it higher so that we can investigate or put some investment around that?
The data that we've been able to review thus far indicates that the means and methods that individuals in Tarrant County utilize for suicide attempts are oftentimes firearms, and the success rate for firearm suicide attempts is about 95 to 98%. And so we do have a higher level of individuals in Tarrant County utilizing guns for suicide attempts. And That is certainly one critical factor.
Okay.
Questions?
Questions?
Okay. If there are no
Thank you.
questions or recommendations, then I do need a motion to approve the proposed annual incentive goals.
Ms. Dorothy, I've got a question. Hang on, Ralph. Can you hear me?
I can hear you. Go ahead.
Okay, sorry. First off, I'm not. Are we in a closed session or open session? I'm
We're in
unclear,
open
and I'm on
session
the.
now.
Okay.
We're in open session. We're going to go in closed session after I get this. Okay. But you want to hold this until after closed session?
As long as legal counsel's on and can guide me whether or not my question is considered a closed session item or something that can be discussed. Will we be going into closed to talk about the LTIP and the incentive plan?
Yeah.
Okay. I'd like to ask my question in closed before we make a motion and vote.
Okay.
If that's possible.
Well, then I'll pull that back, and then what I will do is go into closed session. I will end our open session. The HR committee will now go into closed session. The closed session is being held pursuant to section, I think it's 551.07, okay, of the Texas Government Codes, okay? So we'll give a few minutes, and so for those that's not to be in closed session, then we'll go right into closed session, okay? All right, we are back into open session now, and so we have a couple of items that we still need to address. If we go to 5, there is the first one is for the annual incentive plan and long-term incentive award. If there are no discussions or questions, I'll entertain a motion for approval.
Approval.
Okay.
Second.
Okay, was that Charlie and DT or Ralph and DT?
I think it was all of us. Good.
Okay. All right, so I'll go with Charlie and Ralph on that one, okay? Are there any, all those in favor signify by saying aye.
Aye.
Any opposed? I think I'll do like Roger, I'll just do all opposed. Okay, the next one is an annual incentive plan goals for 2021. If there are no questions or comments, I'll entertain a motion for approval.
Move approval.
Okay.
Second.
Motion by DT, second by who?
Zim.
Zim, okay. Are there any opposed to the annual goals for 2021? Okay, there are no opposed, so that's approved unanimous, okay? And last is for long-term incentive plan goals. If there are no questions or comments, I'll entertain a motion for approval.
I move to approve.
Zim approved. Who's the second?
I'll second it.
Okay, DT beat you, Chuck. Okay.
It's all right.
It's been moved by Zim, second by DT. Are there anyone opposing those? There being no opposed, so it is approved. All right. There being no further business, I will entertain a motion for adjournment.
So moved.
Okay. All right. Then we are adjourned. Listen,